Let's talk about conservative options. So, earlier data, there was a lot of oral options. There was a lot of things that you could try. Are there oral options now that you recommend?
Yeah, the only one would be daily Cialis. We've tried things over the years from Potaba to tamoxifen, colchicine. Pentoxifylline is probably the one that had the best data over the years. Tom Liu was a legend up at UC San Francisco. I did some pretty compelling work with, observational work with pentoxifylline. It makes sense. It's an inflammatory cytokine inhibitor. And so if you look at the initial pathophysiology we're discussing, penis senses it's upset, it has an injury, it starts sending all these cytokines down to make a scar. What if you could give them something to prevent the body from putting a scar down there? And that was the rationale for pentoxifylline. And it showed maybe 40% efficacy in certain men, and it had to be in the acute phase, which again makes sense because if it's mature already, those cytokines are long gone. They've cleaned up their scaffolding and went on to the next construction site, so they're not there anymore. But the acute phase, maybe it works. So I'll offer that. Our guidelines for the American Urologic Association say, really no oral medication has any degree of evidence that it works. But some men want to try something and they don't want to get aggressive with their therapy. And so most of those things are harmless and most men tolerate pentoxifylline fine. So I'll offer it. We call it our anti-fibrotic therapy. A lot of us will throw in citrulline or L-citrulline, which is an amino acid that is easily converted in the liver in the kidney to nitric oxide. And so maybe you're increasing the substrate with citrulline, and then you're blocking the breakdown with tadalafil, and then pentoxifylline actually works on a totally different cascade. So that works. Some guys do fine with it. We don't know. About 10% of men will spontaneously resolve, and the acute penile traumas tend to do better. There are men that really will break their penis or almost break it, not to the point of maybe going to your or my operating room to fix, but at least to the point where they know they had a spot, they know they had bruising, and those can just get better because they have normal wound healing and they just hurt themselves and it got better. So maybe you're missing or you're including some of those men in the pentoxifylline arm that we're going to get better on their own anyway. So I don't really spend a lot of time with conservative therapy, but I offer it. Yeah, for sure.
Yeah. And so when someone comes in the early phases, what do you tell them? What's their chance of getting worse?
There's no great studies to show this. There's some of the earlier studies from the 1970s that said it was a third, a third, and a third, right? So a third would get better, a third stays the same, a third gets worse. And we know that's not true at all. And so nowhere near a third get better. And most of the time in the acute phase, they will notice a pretty dramatic change. They could wake up the next morning and have a 45-degree angulation, and those men, they tend to stay in that realm. So what they get acutely is what there is, and so I don't typically quote them numbers because again, I'm really against just saying just go home and don't do anything about it. Almost everybody I would at least offer some kind of oral therapy, and I don't do any of the transdermal therapies that are out there that people are selling for stupid amounts of money for topical verapamil. And there's a really great, really elegant, again, quote John Mulhall on this study where he put topical verapamil on men, took them to the OR for their plaque excision and graft, and then sent the plaque, and there's zero verapamil ever gets anywhere near the plaque, right? So the transdermals there's just no real good evidence that they work at this point. Very expensive, but they're looking at new emollients, looking at new ways to do it. There's some interesting subcutaneous thoughts that if you could get it under the dermis and some of these long-acting subcutaneous reservoirs, that's kind of cool. I'm kind of interested in that, but nothing really even in a phase 1 study yet. But those are things that my mind thinks about, is if you can get something under the skin that just sits there in a reservoir, then slowly elutes, maybe there's something to that.
Yeah, that is interesting. What about shockwave therapy?
Yeah, so I think the data on shockwave are compelling now for erectile dysfunction, for upregulation of smooth muscle, and so I think that's probably going to be very close to being more widely accepted in the scientific community. It's been offered, as you know, for 20 years or so. In the Peyronie's, I never understood the mechanism. Right? If you don't understand the mechanism, then it's hard to promote something. The one thing I would have a shockwave that I'd be very interested in is and again, this would all be experimental, but if you combine Shockwave with something that actually effects change in the plaque.
Yeah, because the Shockwave would be like the daily tadalafil, maybe.
Yeah,
you know,
you're right.
The same sort of.
Exactly. And Shockwave does have, there's pretty interesting data in the orthopedic literature about it promotes wound healing, promotes upregulation of tissue healing, right? So great, but I don't know that we can go in and shock a mature plaque and make it go away. So you need something to make the plaque go away and then potentially shock it. And that's interesting. And that's something that I really want to look at more. I mean, I know anecdotally there are men that are doing intralesional therapy and Shockwave. And I think if we can get a nice trial together for that, I'd be super excited to see that, because I think right now the world of Shockwave is there's a lot of fascinating research being done, a lot of it in Europe, that I'm very excited to see where it goes, not just in erectile dysfunction, but other urologic issues and chronic pelvic pain, for example, which you know a lot more than I about.
Yeah.
But I'm super excited in the microbiome changes. So yeah, no, I'm definitely interested, very interested, but I can't quote you a paper yet.
Are there other things like transdermal, whatever, verapamil, or other things that are being marketed to patients that are not necessarily effective?
There's another newer molecule that's out there that has a better. It's basically just nifedipine, so it's just verapamil with a different emollient, and it the idea is that maybe it gets into the skin more, but again, we've never done a study. We need to see, will that emollient allow this molecule to get further in, and it's still a calcium channel blocker, so it's still just a generic, a different form of verapamil.
Yeah. I mean, the transdermal penetration and then through a plaque, that's hard. That's really difficult.
It's hard. You got to get through the neurovascular bundle. I mean, there's a lot of real estate between the skin and the plaque. Yeah. And then, as we were saying, plaques are heterogeneous. They're not all just chunks of collagen. There's calcium deposition in it. There's a lot of other. It's a very, very wild west of inflammatory proteins in there, as Dr. Ellis-Warp is studying. So yeah. So I think it's just a salve. It could be purely the fact that when you're putting in anything topically, you're rubbing it in, you're maybe doing a little modeling, and that modeling of breaking up the protein. Because we know that if just even that mechanical changes in traction from both the IMPRESS study as well as penile traction devices, it may seem to do something. So maybe if you're really vigorously massaging a topical in there, you can be, putting anything on it, but it's the mechanics that's doing the heavy lifting.
So let's talk about modeling and traction devices. What is modeling and how can patients do it safely?
Modeling is purely just stretching the penis, mostly in the flaccid state. And the way I describe men to do it is to just grab the head of their penis and pull until it hurts at the base of their penis. Our penis is held to our pubis by suspensory ligaments, so you can't just keep pulling it. And so pull it until you feel those ligaments engage and hold it there for about 30 seconds and relax and do it again at least 3 times a day. And all you're doing is you're trying to longitudinalize those plaque proteins that are abnormal and maybe training it to go in the direction you want it to go. The second part of modeling is to just flex the penis in opposite the direction that it's bent. So if you curve up, you put your penis on the bottom side of your penis and pull down right as wherever your curvature is greatest. So that would be your fulcrum. And again, as part of an intralesional therapy, modeling works. Modeling independently has pretty good data. Traction is kind of passive modeling where you set it and forget it. And that is multiple different traction devices on the market from $30 to $600. And essentially all you're doing is wearing braces for your penis. So the idea of traction is that constant strain on those proteins is actually modeling or changing the fibroblast infrastructure, which is what sets down the new healthy collagen into a more linear pattern. So you're not getting that scrambled egg plaque of what a collagen protein plaque looks like, and just kind of elongating it and getting it back. Also, for those people that are interested in it, which I know is a small subset of your population, it can improve penile length too. So there is something to that. And the question is, how compliant do you have to be? How long, is it like anything else that's physical therapy? You get maybe 2 centimeters of your lost penile length back, but are you doing this every day for the rest of your life, or can you do it for 3 months and it stays? And really, really don't have amazing, annual data on this.
Yeah. I agree. I think that traction is great. It's safe. It's pretty easy to do, but it does require sort of a commitment and maybe a long-term commitment. We don't know.
Right. Yeah. And I think the only thing I do have I have some concern around traction and combining it with intralesional therapy just because of the bruising, swelling that can happen. I definitely have had men that have felt a lot more discomfort with traction, even had some skin breakdown. So you have to be really careful with that situation. And guys, some people overdo it, right? Yeah. And if you say do it for a half hour a day, they'll do it for 7 hours a day. And then you can get some nerve stretch, a little bit of neuropraxia where you get a little numb penis. So right, very safe if used as directed.
Exactly. Used as directed. Yeah. When you have erectile dysfunction and Peyronie's, we counsel patients. Sometimes you can do something like intracavernosal injections of medication. So can that cause another plaque, right? If someone is already at risk for getting these plaques, can that cause another plaque? And if you don't have any plaques and you're just a regular guy, because you're potentially injecting usually around the same place every time, are you at risk as well?
I love this question because I don't understand it. When you look at all of the risk factors for Peyronie's, it comes up over and over again in intracavernosal injections. So you're sticking a vasoactive agent into the corpora cavernosa, not into the tunica. And this is sort of a pet suspicion of mine, is that when men, and again, this is sort of in the older days, a lot of this literature comes from before even the PD5 inhibitor days. So here's a therapy, brand new in 1981, 82, 83, where men that had not had an erection for decades could go to their doctor's office, go to the corner store essentially in some of these pop-up shops and get an injection. And then all of a sudden they say, whoa, my penis is curved. Well, maybe it got Peyronie's 10 years ago, and now this is the first erection you've seen to know that you actually have a plaque. So I don't know. I mean, I definitely see a lot more corporal fibrosis with intracavernosal therapy, where the actual penile tissue, the erectile tissue, with repeated injections in certain men will develop thickening. So I don't know truly how much of a risk factor it is for developing Peyronie's as it is just for the fact that you've had a fallow penis for a long period of time, and the first time you got an erection, whoa, here it is. Having said that, I still think that intracavernosal therapy is amazing, and I have men that have been on it for decades, and I love doing penile implant surgery. I do a lot of them, and I think it's an amazing operation. But I never sell a guy on a penile implant before I say, hey, look, if you're cool with this, have I got a medication for you? It's like $2 a shot. It's really safe if we get the dosing right. I'm going to teach you how to do it, and you're going to be off to the races. Then you do that. What's the worst that can happen, doc? Well, you could develop scar tissue and you're going to need a penile implant. But right now, if the pills aren't working, what are our options? You're going to need a penile implant.
Right.
So that's sort of how I look at intracavernosal therapy. If they develop a mild curvature as a result of just age and genetics and all the other things we discussed, and we'll deal with that later. But yeah, I like ICI as a great therapy for the right person.
Yeah, I agree. And the needles are really small. So it's the trauma to the tunica is like nothing.
Right.
Right? So they're really small needles.
Yes.